So, when you prescribe an antibiotic, you prescribe it as either a prophylactic dose to prevent the occurrence of a disease, as an empiric antibiotic when you don't have the uh, culture and identification sensitivity report, as a targeted therapy when you actually have your culture sensitivity report on you. So, why does AST interpretation matter? It matters because it is useful for diagnosis and therapy. It allows safe de escalation when the patient is improving, prevents unnecessary broad spectrum antibiotic use, and supports infection control and local antibiogram development. So, what did we learn in Module 3? We are going to look at the definitions and understand what is MIC, zone diameter, breakpoints, and how do you interpret the SI, R, and SDD reports, and how do you integrate them into your clinical practice. So when you actually get an AST report, what does it usually contain? It will show you the organism, whether it is an identified bacteria or fungus, the specimen that was sent, urine, blood, sputum, body fluids, pleural, ascitic, CSF. Then it'll give you a drug list of the antimicrobials that have been tested. It will tell you about the MIC, which will be a numeric value. And then it'll give you the SIR and SDD, which is interpreted using the breakpoints. So remember, never read S and R alone. Don't jump onto treating the report. Read it with the underlying organism, the specimen, the drug, the MIC, the dose that you're going to give to your patient, and the patient severity, which needs to be reassessed. Now, right from sample collection to AST report is a process which involves collection of the sample, transporting it to the lab in appropriate media wherever it is indicated. Then the lab puts it to culture, gets the identification and the antibiotic susceptibility test report, and that's when you get your final report from the lab. Now, it is important for you when you're collecting your sample that you prevent contamination of the sample. For example, if you are sending a blood culture, remember that you should send a paired blood culture and at least minimum 10 ml should be instilled in each of the bottles for your blood culture. Do not interpret the report as soon as you get it. Interpret it with the clinical syndrome and the imaging. Communicate the severity and the source to your microbiology lab so that they can give you results accordingly. For the lab, they should standardize the inoculum and media, use validated methods and updated breakpoints, perform quality control, and suppress misleading drugs. Now, there are various AST methods. One of the common ones that we see is the agar disc diffusion, the Kirby-Bohr method. Then various methods that give us the MIC, like the gradient diffusion or the E-test, the broth microdilution, which remains the gold standard. Then there are automated ASTs, which are very widely used in a lot of centers these days, and molecular tests. Just something in brief before we discuss the AST methods about molecular tests. Now, molecular tests give you the resistance gene. They are very rapid tests, of course, but giving you the resistance gene just does not mean giving you the full susceptibility profile, which you should remember about the molecular tests. Now, I just talked about these methods for MIC determination, the broth microdilution, the macrodilution, the agar disc diffusion, gradient diffusion, and the automated. Like this is showing you the Vitek 2 machine, which is also one of the automated methods. So let's understand the disc diffusion to begin with. What happens on an agar plate? So bacteria are evenly spread on the agar, and the antibiotic discs, as you can see here, the white discs on this agar plate, they diffuse into the agar. And it gives you a clear zone of inhibited growth. Now, this is the zone which is measured in millimeters. Now, remember that zone diameter and MIC are related, but neither should be interpreted without breakpoints. So, zone is compared with a breakpoint table. When you have a large zone diameter, more growth inhibition around the disc usually corresponds to lower MIC, may become susceptible if it is above the zone of breakpoint. So the breakpoint is the table which decides whether it is S, I, or R, not the visual impression alone. Now, another phenotypic method that I just talked about was the broth microdilution. So the lowest concentration of an antimicrobial that results in the inhibition of visible growth of a microorganism is the MIC. And as you can see in this picture, At 4 microgram per ml, there was complete inhibition. So, and of course, subsequently at the higher concentrations as well. So this is your MIC. Now, common methods for MIC determination we just talked about. Of course, the broth micro dilution gradient e-test. There are automated systems as well. Now, how does an automated system work? We use Vitek 2 at our center. For using an automated Vitek 2 or any automated system, you need to have culture growth before that, because it's from that culture growth that the pure isolate is picked up from a fresh colony. Then the inoculum is standardized to define turbidity or instrument verified density. Then it is suspended, and the organism suspension is loaded into cards, panels, or wells containing antibiotics. And the instrument incubates and reads the growth signals over time. And software converts patterns into identification and susceptibility results. So this is basically the function of how an automated system works. So just to recapitulate, that you have a blood sample, through virtue you've detected that there is a positive signal. Immediately in the lab, it will be put to a gram stain and a culture. From the culture, a pure colony will be picked up and processed, like we just talked about the Vitek 2 processing. The Vitek 2 will give you the identification and the antibiotic susceptibility testing, and you will receive your final report, which will guide you to your therapy. Now, this was recently published in JAMA, wherein they compared the rapid antimicrobial susceptibility testing to the standard AST, showing whether it was showing any improved clinical outcomes among individuals with bloodstream infection, which is caused by gram-negative bacilli. So it was seen that rapid blood culture AST for gram-negative bacilli was not superior to standard AST for a more desirable outcome in patients with bloodstream infection. Now let's understand what is MIC. MIC is the lowest concentration of an antimicrobial that inhibits visible growth of the microorganism. So the first tube or well with no visible growth is your MIC. And of course, at concentrations higher than that, you would see inhibited growth. So MIC is expressed as milligram per liter or microgram per ml. It is a lab value, not a dose. And a low MIC automatically is not automatically the best drug unless the breakpoint and the site are considered. So everything together has to be incorporated before you actually choose an antimicrobial agent. Let's understand this with an example. For example, your patient's blood culture is growing E. coli and you've tested it for 4 drugs, 4 antibiotics, as seen here, A, B, C, D. And you can see that your lab has given you the MIC values. Now for A drug, it's 4 and for D, it's 1. So, you are automatically, you think that D being having a low MIC, should you choose drug D because it has the lowest MIC? So the answer to this is actually not necessarily, because different drugs have different breakpoints and achievable concentrations. So MIC becomes useful only when it's compared with the correct clinical breakpoint. And also you must keep in mind that the drug that you're choosing, the organism that you're treating, the dose, the PK/PD, and infection site all matter. So it all has to be integrated together in your report before choosing the appropriate antimicrobial agent. Now, what is this breakpoint? So breakpoint is the MIC threshold, which is used to categorize an isolate as S, I or SDD or R, right? Now, if your MIC is lesser than the breakpoint, this means that that particular antibiotic is sensitive. Similarly, if your MIC is higher than the breakpoint, then that means it's R, it is resistant, it will not work for the microorganism, the particular antibiotic drug. Similarly, for I and SDD, the breakpoint, the MIC is going to be close to or nearly the same as the breakpoint, which will give you the I or the SDD report. So the breakpoints are actually given by UCAST and CLSI. Every year they are updated and they are based on wild type distributions, PKPD targets and dosing, drug concentration and infection site, and clinical outcome data whenever it's available. Breakpoints differ by drug, by organism, and breakpoint should be higher than the MIC. So let's again look at our report. I just told you that E. coli was grown on a blood sample, and as you can see, the 4 antibiotics were tested. Look at antibiotic A. The MIC is 4 and the breakpoint is less than 32. So your MIC is lower than the breakpoint. So this antibiotic A becomes sensitive, right? Similarly, look at antibiotic B. The MIC is 4 and the breakpoint is less than 8. Again, it's your MIC is lower. So again, the interpretation would be that this is sensitive. For antibiotic C, it's near about the same, 2 and less than 2. So again, borderline. So the report would give you I. And for antibiotic D, the MIC is actually higher than the breakpoint because the breakpoint is less than 0.5. So your drug has become resistant. So a lower MIC can still be resistant if the breakpoint is even lower. You must remember this. Now, how do you integrate this into your practice? How would you select? I just showed you 2 antibiotics which were sensitive, uh, which were sensitive, right? So, which one out of A or B would you choose for your patient? This is based on the breakpoint to MIC quotient, which is susceptible breakpoint divided by the patient isolate MIC. Now look at drug A. The BMQ is 8, so more buffer below the breakpoint. And drug B, the BMQ is 2, susceptible but closer to the breakpoint. So higher BMQ suggests more pharmacodynamic space. So you would select drug A. Now, but again, even for BMQ, do not use it alone. Always remember the site you are treating, the toxicity of the antimicrobial that you are selecting, the dose that you're going to give it in, whether you've achieved source control or whether done measures to control the source or not, and of course, guideline preference. So, all this again has to be considered with each of these to be able to select a proper antibiotic for adequate treatment for your patient. Now, there are certain definitions of this SI and SDD. So, what are these? S is high likelihood of success with usual exposure. Use if clinically appropriate. I from UCAST means susceptible with increased exposure. Optimized dose, route, and site exposure. Then I from CLSI is intermediate, possible at high exposure or concentrated sites, clarify dosing and site. SDD is only given by CLSI, which is susceptible dose dependent for defined bug drug pairs. Likelihood of therapeutic success if exposure to the drug is increased by adjusting dosing regimen. And R is high likelihood of failure even with exposure. Avoid unless no alternatives are available. So we keep talking about CLSI and EUCAST. What is CLSI and EUCAST? These are two organizations. CLSI is Clinical and Lab Standards Institute and EUCAST is European Committee on AST. They give you breakpoints annually, which are updated. And the key table for CLSI right now is M100. And the EUCAST version 16 is for 2026. Breakpoints may differ from UCAST for some bug drug pairs in CLSI, and in UCAST, they are much stricter and they're different for some agents. So do not mix these tables casually. Now, why does dose and site matter? So there is something known as pharmacokinetics and pharmacodynamics. Pharmacokinetics is the serum concentration, the urinary concentration of the drug, whether it reaches your lung epithelial lining fluid, whether it has some CSF penetration, uh, how much drug is protein bind, how does the renal function affect. And pharmacodynamics is like for example, for beta lactams, it's the time above the MIC. Vancomycin and fluoroquinolones, it's the AUC by MIC. Aminoglycosides, it's peak by the MIC. So dose optimization can change success. Remember, S does not guarantee success if the drug does not reach the infection site or the source control is absent. Then why breakpoints change over time? Because they are not permanent truths and they are updated as evidence changes. Because new PKPD data keeps coming, newer resistance evolves over time, outcome data changes, breakpoints are revised. So lab needs to update. You need to constantly be in touch with your lab and ensure that the lab is being updated annually. Now, when there are no valid breakpoints, what should you do? You should report the MIC without SINR when no breakpoints exist and add a clear interpretive comment. Do not borrow breakpoints from unrelated organisms. You should not be doing that. Now, quality control is another part which is important, especially when you're AST reports are concerned. There are various errors at technical level, at system level, and even at the lab level. So, like, let's look at one of the errors at the lab level, which is like a major error, a false susceptible report, which is very dangerous. You've received a report which shows that your organism is susceptible to a particular antibiotic, but the truth is actually resistant. So what would it do? It would actually result in a treatment failure. So it is very important that quality control is maintained, and it's regularly uh, maintained by your labs. Because, and if you do get an unexpected result, you should repeat the sample. You should send a repeat sample. You should discuss with your lab. You should confirm the result again before just jumping on and treating the report. Now, MIC is important for every drug and antimicrobial that you test, but but it is essential in certain cases, like colistin for enterobacterials and acinetobacter, because disc diffusion is unreliable and there's a narrow therapeutic index. Vancomycin or daptomycin for S. aureus, because small MIC differences can affect serious infection. Penicillin or ampicillin for strep viridans, because in sterile sites, because it can defer your decisions when there is endocarditis, bone, blood, or CSF infections. Xenotrophomonas maltophilia with selected agents, you must use validated methods. So another pitfall, when you talk about antibiotics and organisms, there are certain pitfalls. Another one is the intrinsic resistance. Now, your report may show that the bug is sensitive to that particular antibiotic, but because of intrinsic resistance of the organism, the antibiotic may not be effective for your patient. For example, aminopenicillins for most gram-negative bacilli, even Bacteroides fragilis, cephalosporins, like in cases of Enterococci, Listeria, atypical, Proteus vulgaris and Providentia for first generation, carbapenems for MRSA, Enterococci, Stenotrophomonas, and Burkholderia, aminoglycosides for anaerobes, tetracycline for Proteus species, polymyxins for all gram-positive organisms, and even for Proteus, Serratia, Morganella, and Burkholderia. So even if these organisms are sensitive, these antibiotics are not going to be effective because of the intrinsic resistance. Another pitfall uh, uh, is one is intrinsic resistance, the other is the site-specific antibiotic. It will show that the antibiotic is sensitive, but the antibiotic does not penetrate that site. So again, it will be ineffective. Like in urine, macrolides, moxifloxacin, chloramphenicol, clindamycin, poly, they don't penetrate. Lung in lung infections, gram-positive daptomycin is inactivated by the pulmonary surfactant, so it will be ineffective. Colistin does not penetrate the pleural space. For bacteremia, TG cycline is not a good drug. In CSF, macrolides, clindamycin, tetracyclines, and aminoglycosides, as well as first and second generation cephalosporins, have a poor penetration. So you must remember the site as well before choosing the antibiotic for your patient. Now let's look at these cases. These were shown by Dr. Camilla Rodriguez, ma'am, and we're just going to look at them again. So this was an 18-year-old woman with dysuria and frequency. Urine routine was showing pyuria and nitrite positive. Empirically, the patient was put on amoxicillin, and when the culture report came, it showed E. coli and ampicillin was resistant with an MIC of 32. But the patient, when comes back after 5 days of therapy, is doing very well. So you're provoked to think that is your report wrong? Should you change the antibiotic because it's showing a resistance? What infection site is being treated, and what concentration does the drug reach in the bladder? This was a case of uncomplicated cystitis. Now, many AST interpretations are based on serum achievable levels. In cystitis, some drugs reach much higher urinary concentrations. So as you can see that the bladder concentration was 600 microgram. So ampicillin at 32 is still effective in cystitis. However, if this was a case of pyelonephritis, sepsis, or meningitis, then it needs more systemic exposure. So if your patient is not getting better, at this point, you need to reconsider your antibiotics and change if it is needed. So do not extrapolate urinary success to bacteremia, and use serum and organ-specific breakpoints and severity assessment. For cystitis, bladder concentrations may exceed the serum-based breakpoints. Some drugs have urinary breakpoints. So clinical improvement matters if infection is uncomplicated. Now, another aspect for urinary infection is the urinary pH. There are certain drugs which are effective only in acidic urine, like the nitrofurantoin and penicillins. So, if a patient with UTI, nitrofurantoin is one of the drugs which is very commonly used and comes with UTI, and you give, alkalizing agents for dysuria. So, you must remember when you're using an antibiotic nitrofurantoin that the effectiveness will go down. However, there are some antibiotics which are effective in alkaline urine, like the sulfonamides, the kanamycin, colistin, tetracycline. So these aspects also need to be considered before actually choosing the appropriate antibiotic. Now, again, a specimen of urine sample from a patient which was growing Proteus vulgaris, and you can see the sensitivity report. So, what antibiotic would you choose for your patient? Now, remember that you have that report is showing Proteus vulgaris. Now, Proteus vulgaris, Providentia, and Serratia are resistant to ampicillin as well as first generation cephalosporin. Proteus species are also inherently resistant to nitrofurantoin and tetracyclines. Nalidixic acid sensitivity predicts susceptibility to all fluoroquinolones, but your report is showing resistance to your fluoroquinolones. And chloramphenicol does not achieve adequate levels in urinary tract infection. So, from this report, with all this, I don't think I can select any drug. So, each of the organisms, when they're isolated, you need to remember that you cannot blindly jump onto the AST report and start treating. There is intrinsic resistance, there is site, there are other things that matter, which always should be remembered. Another case of a 65-year-old smoker and diabetic with right upper lobe pneumonia, ceftriaxone for 4 to 5 days. Sputum sample was sent after the antibiotics. And the culture of this patient from sputum grew Enterobacter agglomerans and Candida albicans. Now remember that for a sputum sample, it's a non-sterile sample first of all. I told you that the antibiotics were already started and the sputum was sent. So antibiotics select colonizing flora. And Candida and sputum rarely means Candida pneumonia. So don't escalate to carbapenem just because the colonizers look resistant. This is another very important aspect before just jumping on to changing antibiotics because the culture sensitivity report is showing something else. So remember, if you're unnecessarily treating resistant colonization flora with broad spectrum drugs, you are generating more antimicrobial resistance. And if you're treating a colonizer, you may actually miss a true pathogen or a non infectious cause for the patient's problem. Now, another aspect in pneumonia is, non-responders. So it's not just your AST report that matters. You need to reconsider, relook. Are you treating a wrong pathogen? Is it a viral infection or tubercular? Has a complication occurred like an abscess or a parapneumonic effusion? Is the diagnosis wrong to begin with? Is your host immunocompromised? Has comorbidities like diabetes? And treatment factor. Have you chosen the right dose? Have you selected the antibiotic which penetrates the lung? And have you ensured source control? Because if you should not just treat the report, treat the patient plus the syndrome, and always look at the microbiology simultaneously. Now, for blood culture, how do you differentiate between contaminant and true bacteremia? Cons in one of one set is often a contaminant, so you should repeat cultures, reassess your lines and prosthesis. Cons in one of multiple sets is again usually a contaminant, so do not jump onto adding a gram positive cover. Cons in multiple sets is more likely true bacteremia. You need to evaluate your catheter, prosthetics, as well as look for endocarditis. Staph aureus in blood is usually clinically significant. It's a serious infection and you must look for source. Then, source control dictates response. So you need to identify the focus, remove the drain or the line if that's the culprit, culture properly, ensure that the antibiotic that you're selecting reaches the site of infection to achieve a desired clinical response. Like in case of empyema, drain the pleural space, relieve the urinary obstruction, remove the catheter if that is the source of infection. Persistent fever with an S report should trigger source control review, always. Now, another case of a patient with repeated blood culture positive Staph aureus infection. Patient was on vancomycin for about 10-12 days and suddenly starts worsening, now develops multifocal septic arthritis, spondylodiscitis, vegetation. And the report is showing that it is still the Staph aureus is still vancomycin susceptible. So then you are provoked to think that is the bacterial burden high? Is the focus more deeper? Is MIC near the upper susceptible range, or the MIC is it the MIC creep? Now, what is MIC creep? It's a gradual upward shift in MIC values over time. While the lab may still report the isolate as susceptible. Let's look at this with an example for vancomycin, MIC, and MRSA. As you can see, initially it was zero point 0.5, but then gradually it kept creeping and reached near about the breakpoint 2. So it is, still susceptible, but the MIC has creeped. So when the MRSA, vancomycin, MIC is near about 2, then you need to reconsider if the patient is not improving. If the patient has pneumonia, you can consider linezolid when it's clinically appropriate. In cases of bacteremia, you can consider daptomycin. Then vancomycin and the MIC basically. So if the MIC is less than the breakpoint and the patient is improving, then you continue if the exposure is optimized and the source is controlled. If the MIC is less than the breakpoint, but there is persistent bacteremia or worsening, reassess source control, repeat cultures, consider alternative therapy. If MIC is more than the breakpoint, then there's a concern of VISA and VRSA. So avoid using vancomycin. And for serious MRSA infection, aim for AUC by MIC targets with therapeutic drug monitoring. Avoid underdosing in such infections. So, rapid AST is something which is very helpful and is very widely used these days. But when it is used, it should be paired with a good sample, quality control, stewardship, clinical and microbiologist communication. Because rapid AST would help you in earlier targeted therapy, earlier de escalation, reduce unnecessary use of broad spectrum antibiotics, and better ICU decision making. But the speed alone will fail when wrong specimen or colonizer is misleading you. So you need to remember that it has to be integrated together. Now, when you get an AST report, how does an ideal AST report look? It should state the organism and the specimen clearly, provide MIC where clinically important, show the breakpoints or the interpretation basis, use current and updated CLSI and EUCAST versions, suppress drugs with intrinsic resistance, add comments for no breakpoint situations, and flag urgent results for bloodstream and ICU infections. The best report is not the longest. It is the report that prevents wrong treatment. Now, the lab has to maintain quality control and a checklist, but a clinician should also remember a checklist before jumping onto the AST. Are you treating a true pathogen or a colonizer? Was the specimen taken before or after the initiation of antibiotics? Is the patient improving or deteriorating with the treatment that you've started? Does the drug reach the infection site? Is MIC close to the breakpoint of the antimicrobial that you've selected? Has the source control been achieved or not? And does the guideline here match the current standards? So this is a checklist that you must always keep in mind before actually acting on your AST report. So the stepwise bedside algorithm is that you confirm infection, confirm the pathogen, check the site, read the report with MIC and the breakpoint, optimize the dose, and control the source. If there is severe illness, prioritize reliable early coverage and then de-escalate. If borderline MIC or SDD, use recommended higher exposure, not the routine dose. And if there are no valid breakpoints, do not force SI and R. You should seek expert inputs. So just to summarize the definitions, MIC is how much drug is needed in the lab to stop visible growth. Breakpoint is the cutoff that converts MIC or the zone into your report of SI by I or SDD or R. S is likely to work if the right dose reaches the right site. R is likely to fail, avoid if alternatives exist. CLSI and UCAST are rule books, but remember that the once you've identified the organism, the right drug, the MIC, the site that you're treating, the dose, whether you've achieved source control or not, and assess patient severity is how it should be clinically interpreted and put into use for treating your patient's infection. So, AST is a decision support tool. It is not a substitute for clinical judgment. Thank you.